Now no, he's going. Yeah.
I think let's open it to questions.
All right, open it to questions. Yeah, sure.
You're like becoming like morale now. You're in such a hurry. My gosh, relax a little bit. Like Tyra and I were just saying, isn't this a fun meeting? We can just relax a little bit. Listen, the mechanical pulmonary, that was one thing I got up to talk about. Those don't end well often, so I would be careful with that. But my real question was this graft and then the bioprosthetic sewn in the middle of it and then to the distal PA. What we learned early on in the which we've done quite a few of them in the carcinoid patients, open up the Bo, this is for you. I love root enlargement. I just don't like size 29 or 31 in little old ladies. But in the pulmonary replacement, we like to open into the RV outflow tract, put in a big valve, patch the top, and then you can have your stent in there later. Why wouldn't you do that?
Well, I think that's a very good point. So after you've had a Ross, that whole RVOT is quite wide. So that ventriculotomy is very wide. So you have a few options. So if you do have a conduit, they can just sew to the back wall too, great. And then you can even patch with bovine pericardium, just like if you do a TET, re-up TET, and you're doing pulmonary valve, same idea. You can do that. But one of the keys is you don't want your pulmonary valve sticking up towards the sternum. It needs to be tilted this way so that because otherwise you're going to get a gradient as it makes a turn. So the key is the position. So if you do, like you could sew to kind of like RVOT, although it's a little fragile, and then do a hood, but you just need to make sure it's tilted towards the confluence.
Yeah, the way you tilt it is you need to make sure that you know these things, I'm sure, since Mayo and us do the most of these things for carcinoid, but the way you tilt it is just keep the patch short, the top of the patch. You've got to tilt the valve down when you start running the top of the pulmonary valve, bioprosthetic valve, into the patch so that you're basically tilting it directly into the bifurcation. That should never be the struts pointing north, or you'll get stenosis too.
It is interesting to note that there's a number of companies out there developing PTFE RVOT conduits, and all of them have the same concept as what you're talking about with the pulmonary valve, much more distal, and the proximal component quite able to be beveled. So you're right on. You're onto something, Dr. Stevens. Chris. Dr. Burke.
Thanks, Joe. My question's for Elizabeth. Great talk. How do you manage the homograft or RV to PA conduit for a Ross reoperation for an autograft indication? So let's say you're 20, 25 years out, the homograph looks okay, it works okay. Do you replace all of those or replace them if you get into it? What do you do there?
Yeah, I think that's a really good question, especially for someone who has had longevity with a homograft. And often patients think that if they've had longevity with one homograft, they will with the subsequent, but that hasn't been shown. So just because you had it with one does not necessarily mean you do with the other. So I think it's a nuanced discussion, but to your point, you're looking at degree of dysfunction and how long it's been in. And then I think most of our surgeons are just kind of wanting it out of the way and are comfortable doing like a twin root, and so they're probably going to leaning towards it's just going to come out. And then you don't have to worry about, as you're working on the autograph, getting into it. You already just have known that you've talked to the patient regarding that. And then the discussion of whether you do another homograft, I think is, obviously with the patient, but some of those patients are really wanting another homograft because they've had good luck with, previous.
Hero.
Hey, Elizabeth, great talk. Quick question, and perhaps now to the rest of the panel as well. Often the time we get a referral for autograft dilatation. When there is not much aortic regurgitation, when would you reoperate for autograft aneurysm?
Well, I'll answer that a little bit. The first one thing is it's really all about the AI. And if you look at the data, it's like Duke Cameron says, it's almost a reportable case to have a true aortic dissection in an autograft aneurysm. Seriously, I mean, when you actually examine it. So I would probably use 5.5, 6, even 6 centimeters. As long as there's no AI, the primary indication usually is AI. What do you think?
Yeah, I agree with Joe. I use 6 centimeters if there's no AI. There are cases of dissection, I've seen them, But because of the suture lines everywhere, everything's protected. The coronaries, distally, you're protected, and proximally, you're protected. So the patient that has a big jump in their root diameter, it goes from 5 to 6 centimeters in 1 year. That's usually the patient that had a dissection, but it's contained. And so I'm not aware of cases of rupture. Maybe we'll never see them because they die suddenly, but 6 centimeters, I think, is a good cutoff. Joe, you had a question? Sorry. Any other different, Gebrine, do you have?
The difference is sometimes even if the aortic regurgitation is not significant,
If you think you can save the valve.
progressive aortic regurgitation will push us to go and replace.
And save the valve.
Save the valve.
Meaning, yeah.
That's the one. Another comment on the root aspect, and the echo, transesophageal echo, or CT scan echo. In many cases, when we have a really root dilation of the autograft, it is asymmetric. We have some kind of rupture inside of that, and this kind of appearance of the autograft really not round, let's dilation, asymmetric one, also will push us at certain diameter to go for also replace this valve.
Joe, and then
this
Eric,
route,
and then
this
we'll
route.
move to the next session. Joe?
Great session, tons of really valuable technical tips. We seem to have accepted RVOT failure. I wonder if the panel could tell us their advice broadly for reducing early RVOT failure and particularly late, including any innovations that we should be looking at. Because we don't seem to have moved the needle in 20 years on that.
I'm very excited about the Otis valve. Dr. Del Nido is probably somewhere here. Oh, right here. So, and he's involved in the development of that valve, but I think that could be a true game changer for our TET patients, for our ROS patients. I mean, like for a whole, as you know, so much of congenital heart disease is right-sided heart disease of the RVOT. So if that really pans out, that could be really exciting, I think.
Elizabeth, that was a really great talk. I just had to step up and just make a couple comments about the reverse ROS. You pointed it out. So in Cleveland, we've done about 175 reoperations after ROSs. 52 of those are reverse ROS. So those are and Gus has done the bulk of those. I've done a couple of them. That's been a real nice solution for the patient who has homograft failure in the pulmonary position and also has some dysfunction of their autograft. Often those patients have had an aneurysm and they've had some AI. So we actually can save that valve. Joe, you talked about the decision to do a David after the ROS. The leaflets have to look good. Interesting, a lot of these, the leaflets, they don't look that great. Like you're not happy keeping them in the aortic position, but when you put them in the pulmonary position, they still function beautifully. And so you still have this living valve that you can put back over there and then do whatever you decide to do on the aortic side. So it's been a really nice operation for teams that are, adept at doing complex redo routes. It takes a little bit of time, but it's a beautiful way to sort of stick to the important principle of saving a living valve.
Good. Thanks, Eric, for this point. Why don't we invite Chris Burke and Mark Peterson to join us at the panel. We'll start the next session, which is the case scenario about ROS with residual. And I think the last point I'll make about your presentation, Elizabeth, for redo ROS is twofold. One is, when it comes to aortic valve repair and ROS, we always talk about reoperation like it's an absolute failure of the original strategy. And I think for young surgeons, that can be a little bit daunting, especially when you're starting your career and you see patients if they come back. We shouldn't call this a failed ROS or a failed repair, because we don't call this a failed bioprosthetic, structural valve, whatever. If the patient comes back with an endocarditis or with a stroke or major bleeding or death, this is a failed strategy in the first instance. So reoperation is really not an absolute failure. In fact, like Morales showed, the reoperation is the safest valve-related complication the patient should hope for. So obviously we want to make the operations very durable, but we should not be thinking about these as failures. We should stop using that terminology of failed autograft and failed repair. Otherwise, it's very hard for young surgeons to actually start doing these operations. And the second point, it goes back to Morales' point about centers of excellence or reference centers that do ROSs at a high volume. If we think that the ROS is a safer operation in high volume centers, a redo after a ROS is all the more so. And so these patients should definitely be referred to centers that are doing Rosses in the first place and that do these operations at a high volume and in a timely fashion, I should say. Because I think a lot of the mortality from the early series is cardiologists sitting on these patients and trying to kick the can down the road so much. And then the patients present with RV failure, with LV failure, et cetera, et cetera. The original Mayo paper, I think almost a third or half the patients had moderate to severe RV dysfunction by the time they presented for their redo. So I think these are just important points.
That's a really important part, in particular LVEF. I was just so surprised that you had all these patients with the EF less than 30% who were now coming, right? Like that is too long, clearly.
And Ishmael, preoperative planning, now always, when you see these papers, for all you young people from the 90s, 1990, 1991, I think that's where it started. We didn't do preoperative planning. I'd never heard of doing a CT before a re-op. Third time redo at the Brigham, it was sort of get in there and do your best. We didn't have nitric oxide. We didn't have specialized cardiac intensivists. There are a lot of reasons why all that was going on. That's not really as relevant the last 5 or 7 years in most valve centers. So we always have to have that lens too when we talk about structural valve degeneration. Ishmael, I couldn't agree more. The term failed Ross came from someone that doesn't like the Ross, because we don't call it failed pericardial valve. We call it structural valve degeneration. At 15 years, you got a great result. But if you get a Ross and you come in 15 years, your Ross failed. That's why I don't like that operation. We really got to be a little smarter in 2025.
Yeah, and you look at yourself in the mirror and you're like, I'm a failure as a surgeon if my Ross failed 20 years after surgery. So we have to be careful with terminology, and it also informs how cardiologists think about these operations if we keep calling them failed autograft and failed repairs. If the strategy worked in the first place, the patient's still alive and we can do a safe reoperation, I would argue this is probably not a bad strategy in the first place. We're well behind time, so maybe 15 minutes, Maral? Till 12:40. Till 12:40? Why don't you stay, Joe? It would be good to have you on stage. I have a few cases that I put together just to tickle your brains about how you approach patients with AI in the context of choosing a Ross. So here's the first case. This is a 28-year-old male, severe symptomatic mixed aortic valve disease, and the TTE shows an aortic annulus that's dilated, measures 29 millimeters, and the rest of the dimensions are essentially normal. So that's pretty typical patient, nothing too unusual about it. This is the echo. You see it was a unicuspid valve. You see the calcium, so the valve is not repairable. This is the short axis. So my question to the panel, if we run it up and down, first of all, in AI patients, should a Ross be considered? Quick yes or no. It doesn't have to be a...
Yes.
Okay.
Yes.
Any instance you would not consider a Ross? Or what are your concerns with the Ross in patients with regurgitation? Why do we make it a separate chapter or paragraph anytime we're writing about the Ross? Gebrine, what have you learned over the last 30 years with Rosses in patients with regurgitation? Why do they fail more, and what are you concerned about at the time of surgery?
I think it is at the beginning, when I was really very young, we also said when we have a bicuspid aortic valve, the bicuspid valve has some kind of aortopathy, and the aortopathy may be also at the level of the pulmonary valve. So that was our general idea, what to learn from our method. Now, in severe aortic regurgitation, we have, I approach the aortic valve like mitral. If you have a severe mitral regurgitation, we have a severe annular dilation. If you have a severe aortic regurgitation, you have severe annular dilation. So it's a question of mismatch between the tissue and the orifice. So if we don't fix the annulus, it will maybe, in young patient, it will continue to dilate or whatever. So for why, I mean, at the beginning, years ago, at the beginning of our experience, we used to fix it with pericardium. Unfortunately, the pericardium dilate, I think, with the autograft, and when it became calcified, it's very large. It is not small annular stabilization with calcium. It's really a huge annular calcium. So it is any protective role of the pericardium. So we thought, I mean, the majority of our patients are those patients, bicuspid regurgitant, no support, not appropriate support. So for why we had this idea that we don't have to do Ross in bicuspid. So for why also came the idea to support
Yeah, I think, in fact, if I quote Dr. David in one of the editorials in the early 2000s, we had mentioned that that these patients with bicuspid and AI are genetically programmed to failure. What's your position now, Dr. David, with these patients? Because I'm quoting literally from your Circ editorial in 2010.
I do not believe in putting foreign material. I use only natural stuff. In other words, plication the annulus or redilate. Then I am into a band along the fibrous part. But the results don't seem to matter anymore much. If you take a look at dilatation of the aorta, compare those patients, we're going to have more information now at 30 years. Both dilate. In other words, most of my cases were the inclusion technique, and the aorta continued to dilate along the pulmonary valve. So I don't know what you guys are doing is going to solve the problem. In other words, annuloplasty like you're doing and put the conduit above the band. Yeah, that
No,
portion
not above the band, inside of the band. It has to be sitting in the basal ring, and the band has to support it. I agree. If it's sitting above, then it's pointless.
No good, yeah.
Haven't done anything.
Well, so time will tell. We're going to have a lot to be learned yet.
Why not put the band on the autograft and implant it after? I mean, because we have
because well, let me answer that if I may, but that's not my position to it. Well, I want to let the panel answer it. Mark, why don't you put the band on the autograft and then implant it in the LVOT, in the larger LVOT?
Yeah, I mean, I've never done that. I've done it where we use the band annuloplasty, and we can reliably get the annulus to 25, 26 when it starts out large. I guess the times where I wouldn't do this is if the annulus, and we don't see it that often, but sometimes it's 35, even 40. I mean, this is unusual, but I've chickened out doing the Ross in those cases. But I guess I would just say that, you know, we've looked at this. When you look at the data from even 20, 30 years ago, and you look specifically at the patients who had AI and mixed ASAI, they actually have done pretty well with the Ross, and that's before the techniques of annular reduction and stabilization. And so I think, you know, just starting from that old data, the results are not that bad. And then, you know, with these new adjuncts, and you've shown over at least a decade that the annulus size remains stable. I think it's encouraging that the results will be at least the same as the historical results and maybe even better. So I don't have a problem doing it in this population.
So what else in addition to the annulus being dilated and mismatch between the two are you concerned about in these patients? Is it just at the annular level, or is it at the body, at the sinotubular junction? Jordan, do you think what's unique about AI versus the other patients?
Well, I do think that all those areas have to be stabilized, and we know based on the geometry that many people in the room have taught us that the sinuses can dilate, and if the ventricular aortic junction and sinotubular junction don't dilate, the valve will remain competent, and that gets back to the question of how long will you let the sinuses get, or how big will you let the sinuses get. I mean, Duke Cameron told me 6.5 centimeters, you say 6. But I do think those areas need reinforcement.
We have some patients without any aortic regurgitation, with aortic stenosis, and they dilate, the root dilate. So I think it's maybe it's the problem of control the blood hypertension or whatever. But anyway, the root dilate also in stenotic, much more in regurgitation, but in stenotic. So I think if we have a risk factor, the whole thing should be stabilized. That's unless if you stabilize only one sinus or two sinuses, maybe the third one will dilate. So for why I think in patients at risk.
Well, you just answered the next question. So for these patients, you put them inside the one in the middle here.
I don't hesitate, yes.
Okay, and if you run down the panel, you have this patient with AI, no root aneurysm. Which technique, Chris Burke, what do you use in these patients?
Yeah, we would probably do a modified Dacron inclusion shawl. It's kind of like a floor to sleeve type of thing. If the patient had a true aneurysm was over 4.5 centimeters, we do a total Dacron inclusion like Dr. Khoury showed before.
Mark?
Picture on the right.
Picture on the right. Gebrine picture in the middle.
The middle.
And how do you choose the size of the dacron, your cardio roots?
Yeah, I mean, I tried many things. Finally, as said yesterday by Tirone, we can see, look at the autograph and choose the. We don't need the rules or whatever. Now, what I try always to be a little bit reproducible in my approach to anything. So what I start to look now, for the last 2-3 months, to look at the diameter of the sinotubular junction of the pulmonary trunk, and and this one usually should give us an idea about the diameter where the autograft the autograft is functioning very well. So I'm trying to this. It is not always, but I mean the last one. Let's say I size 32 on the pulmonary 32, and so I took 30. But that's one way. The second way is if you go back to our way to size in David operation to size the tube, we size the commercial between the left man and me and Laurent. We start doing this. We try to, but it's always which one. So I think if we have a good echocardiographer and we have a good view of the pulmonary trunk, we will give you an idea about the diameter of or the CT scan. Why not?
So what's the usual size that you use? 28, 30?
28, 30. Sometimes it's 32, but it is rare. I mean, 32, the autograft is really very happy inside.
It's loose.
It is, but yeah, 30 the mean.
Yeah, if you're starting out, 28 cardio root is a pretty consistent, probably 28 cardio root will be a 90th percentile, pretty much.
The cardio root is really a very, very good material for that.
Okay, Jordan?
I use technique C, and of course I learned this from you. You have to put the suture such that the pulmonary valve sits within or deep to that ring. So there was a comment made earlier that I didn't agree with about the video. Those sutures have to be under that ring. If the Ross valve is sitting above that ring, you haven't done it correctly.
Can I have a comment on the third? Third image on the technique you use? I mean, I think the quantity of tissue above the commercial is still quite big, and if you have to go back on the valve to assess, it's very difficult to see the valve. So for why I think if you really take the autograft as short as possible. So when you pull, you are at the level of the commercial, so you can have a much better idea on the autograft. So I think it's not good for many things, because this is this area dilate, we know that, and also if you have, by chance or by risk, to go back and to see, you have a lot of material inside, and the valve is not really well. Maybe you have to...
You're talking about this distal suture line at the sinotubular junction.
Yeah.
This is a bad illustration. It looks like it's a lot higher than the commissures. It actually should be much closer to the coronary button. I agree with you, 100%.
Yeah.
Elizabeth?
Yes, C, and basically everybody also gets STJ stabilized with some sort of hemoshield, as you said, pretty close to that commissural post going around. So it adds very little time. Many of them have aortic pathology that you're a little concerned about. So basically everybody gets that, and then annuloplasty in select patients.
Okay, Joe?
Yeah, same, C.
Okay. Okay, I'll skip through these things because we saw many videos. Let me get to the next case. This is a 34-year-old male. He's a heavy bodybuilder, and a serious heavy bodybuilder. He's on steroids, he takes the testosterone, whatever, all the stuff that they do. So he had a bicuspid aortic valve sparing operation with an internal ring annuloplasty 2 years prior. We don't use the internal ring annuloplasty, but this is the operation he had. He now presents with severe AI. What would you guys propose? The aortic annulus is very large. It's 36 millimeters. Huh?
Can we see the echo?
You can see the echo. This is the echo. So you see the annulus is almost the size of his sinuses, and I just want to illustrate this for that internal ring. First of all, the sutures of the internal ring had perforated the leaflet, and look at the internal ring inside the LVOT that's completely dehisced. So just a word of caution with the internal ring, particularly in these patients with very big annuli.
Jesus, look at that
But anyway, so what I want to know is, should a Ross be considered in these patients? Patients, bodybuilders, patients who porters or whatever, who do very heavy, strenuous things, and then we'll get to the aortic annular dimension.
Yeah, I think one thing is what Morale's talk was one of the lines she had was, compliance. And some of these guys are really non-compliant. And I remember before I left Penn, we had, I think, 80, I know the mesh is in the room somewhere, but 84 Rosses, and we had our first redo, Ross was an incredibly non-compliant person. I would be a little worried about that. But other than that, I think there's no reason why you shouldn't do it.
Would you modify your technique? Would you do the inclusion in the Dacron specifically in this patient?
No, I don't really subscribe to that. I think if you hit the annulus properly and you hit the STJ properly, you're probably going to be good. Listen, I've been around and I've done a lot of redo Rosses, and I would say that the vast majority of them are all, when you look at the preoperative note from 20 years ago or whatever, they're all patients who had AI, and they're all patients who had aortic root aneurysms, every single one of them almost.
Usually I'm always for a Ross, but in this patient, I'm hesitating. I'm hesitating because of the drugs he's taking and the thickness of the left ventricle. Usually in those patients, they have such a big stack there. And we are not really, if this guy, you can tell him, stop taking drugs, I put a biological valve. You come 10 years after I do Ross. But in this situation, I will not take the risk to really propose a Ross for him.
The rest of the panel, anybody would do a Ross in this patient?
I have significant concerns in this patient. So what I would say for the more inexperienced Ross surgeons in the room, Ross after a true root replacement, I think is a definite acquired taste, mobilizing Dacron buttons and everything and doing a Ross. So you have that aspect of things. He has a huge annulus. He's going to be bodybuilding, using steroids, whatever. I think if you had to do it and you were compelled to do it, personally, I would definitely do it inside a full Dacron inclusion, but quite frankly, I'm probably thinking Bentall in this patient.
Mark? Jordan?
Yeah, obviously it depends on given cases, but we discussed a patient of mine who was in his 50s who walked into my office. He looked like the giant from the Game of Thrones, and he was bench pressing 600 pounds and deadlifting 1,000 pounds. This guy was a monster. And he wanted a Ross, and I didn't do it. I did a tissue valve, and he came back to the office, and in 3 weeks I said, well, how are you doing? He's like, well, I'm back doing some light weights, and he's already bench pressing 200 pounds. So
yeah, I agree.
It's something
I agree with the whole panel. I think it is a mental condition. It's a psychological almost disease when they bodybuild to that extent.
What is your opinion?
And you can never. We did an AVR as well
AVR,
in this patient,
okay.
although he's young. But so the other question, assume that this patient is not a bodybuilder. He's just a regular patient, but he has an aortic annulus of 36 millimeters. Is there an upper limit where the Ross, where AI, very large annulus, he doesn't have a root aneurysm, okay? It's not 6 centimeters at the root, it's 4.2 centimeters. Is there an upper limit where you say, this something is just a little...
Yeah, that's what I was trying to get at with that question this morning. For me anyway, it's probably somewhere up 6 to 7 millimeter, mismatch, yeah.
So it's only about the mismatch for you, Joe?
For me, it's only about the mismatch.
So that means you will go and harvest the autograft, measure it, and then you'll make your determination whether yes or no you're doing the Ross.
The mismatch is the critical. If you have this big guys, they can have pretty good size pulmonary valves. So for me, it's the mismatch. Once if it's 2 or 3, I just put a little suture annuloplasty in one of the commissures or 2. If it's more than that, I'll put a ring in. And if it's more than 6 or 7, I'd like to hear what you have to say. If it's more than 7, I have a problem.
Have you ever been in that position? Would you just re-put the autograft in place and go back to the left side? Have you had a mismatch of more than 6 where you've aborted after having harvested the autograft?
No.
Okay. Elizabeth?
Agreed. In the 30s, 37 would make us nervous. I do think I guess I don't know how to tease out how much is just the annular diameter itself versus the mismatch. I would say that Mayo historically has been an anti-Ross institution, so I think we've had to be very careful about what we have been choosing in the last 5 to 7 years in our Ross practice.
Jordan, any cutoff point?
Well, I've had some bad experiences with really big annuli, so they do make me nervous. But I think you also have to look at the size of the patient. I mean, if you're operating on LeBron James and he has a 35 millimeter annulus, that just may be based on the size of him. So I don't think there's an upper limit, but I do think you should be very careful if it's big. And interestingly, Ross, unlike almost every other thing we've talked about, I think we're all happier when everything's smaller. Like a 20 millimeter AS Ross is a great and an easy case.
I think if I have to do, if I like to do Ross in big aortic annulus, I will use the double protection, the prosthesis, and do some kind of annuloplasty to really adapt the aortic annulus to the prosthesis, not to the autograft. We might find something like that.
Mark?
So we do structural heart CTs as our standard for workup for a lot of these patients, and it's surprising to me when you look at they're asymmetrical, the annuli, at least on CT. And in the maximum dimension, it's not unusual in some of these patients to be in the mid-30s, even upper 30s. And then you confirm it in the operating room with Hagar dilators, usually 32. Whatever. We don't have a problem doing the operations proposed in those patients, but I think over 40, I have no data. I would start to get nervous. It's unusual. I guess the one question I'd ask the panel, which is a situation I've only encountered a few times, it's usually congenital patients where the pulmonary annulus, at least on CT discussion this morning, noted, it seems to be quite a bit bigger than a congenitally small LVOT, like you have a 19 or 20 millimeter aortic annulus and a 35 millimeter pulmonary annulus on CT. Unusual situation, but in that situation where the pulmonary is way bigger than the aortic, do you have any problems using it in that situation?
The question is that usually in this situation, what I do, if I have to do Ross, is I leave some 4 or 5 millimeters of the aortic wall, and I put really the autograft on top of the annulus. In this situation, you can really, and by this way also, you may a little bit reduce your pulmonary autograft. So this kind of leaving 4, 5, or even 1 centimeter allow you to go a little bit far from the so you put your stitches on the annulus. That's one way. It is exceptional, this, but in some pediatric, I agree. In this situation, you can allow yourself to do something above, but it should be supported somehow.
I think early on that would be a really bad idea to try in somebody's early experience, but Schaefer's has a really cool technique, which he's against Ross Kono in adults. Once you've taken the left button out, you can just split the annulus right under the left coronary artery and patch it right there. It's very easy. The only thing that's there is the left atrium. And he's published this, and he has a good experience. He makes a triangular patch and then puts the Ross on that, and it's very easy.
Yeah, I would argue.
I see Dr. Del Nido saying no.
I think it is the most
In an adult,
area.
I would just simply implant it with the interrupted sutures and let it just it settles. It's a rare instance in adults, but it usually works. Eric, I think you had a question or a comment.
The point about the large annulus, so many of my patients, have a lot of aortopathy, and I liked what Gebrine said about sort of double supporting. So a lot of these, I'll do the supported autograph, like what you showed in the video, but I'll leave a couple of rings of graft hanging below the area where I saw the autograft, and then that's like a sewing ring that you can sew to the big annulus, so you kind of separate it, and then there isn't tension on the autograft. It's worked pretty well for some of these giant patients I've had.
You can use it, yes, but you have to incise it on three places in order to be able to reinforce with this.
Well, you talked about the urologic technique.
Before, yeah.
I want to know from the panel, do you test all your patients for genetics, those who have a root dilatation and AI? They're young. Let's say it's only 4.4 centimeter at the root. Do you do genetics systematically? Do you do a family history systematically before you say it's safe to do a Ross, this patient does not have the heritable aortopathy, or only if it's more than 5 centimeters or they have phenotypic features?
No, but we should.
I have one patient, 18 years, had Lois Ditz, but had a aortic valve replacement some years before. He came to me. So I was really hesitating. What can I propose to her? So I'm not sure, but it was 2 years ago. So I did Ross, supported Ross on her, and she's doing well. That's the only patients when I have really a real connective disease, in whom I put a protected one.
We do test a lot. I mean, if they don't have any aortopathy, probably not. But we end up doing a lot of genetic testing, and I guess the question is what do you do with these VUSs? Because we do get a lot of VUSs, and some patients have family histories, and there's maybe a little bit of dilatation. I guess generally we don't disqualify people from the Ross for that reason, but I wonder if they're at higher risk of failure.
Yeah, I was just going to say, we offer every patient, not only with root aneurysms, but with ascending aneurysms. We have an in-house lab. It's right down. We run the genetic testing locally, and that includes bicuspid patients.
And you would not do a Ross if any of the tests came back positive?
Well, I mean for aneurysm referral patients. If they come back with a genetic aortopathy, I hope like heck they can get a valve sparing. I mean, most of them go down a valve sparing route, so I can't say it's really come up.
Okay.
If you were truly in a pinch and they had AS, probably the closest surrogate is actually Turner's patients, and what to do with those patients. They're particularly tricky, but I'll tend to do some element of autograft protection on them.
Okay, great. Well, Morale is looking at me, and the time is running. I still have 3 more cases that we could have gone through, rheumatic cases, autoimmune cases. I've got a type C anatomy, so many questions, but this has been a great discussion. I think there's so much more to learn, but we can only learn through sharing. So thanks again, Morale, for putting the program together.
Great to see you. Yeah.